talking about treatments of hyperthyroidism. And what our options were. Okay. And remember, we had 3 forms of treatment depending on our situation, whether it be you had drug therapy, radioactive iodine, and then surgery. And we talked about a lot of the drug therapy options. And then we talked about the consequences of untreated hyperthyroidism and what would happen. And we talked a bit about osteoporosis and what causes that in relation to the calcitonin problems from the C cells. Okay, so another option for treating hyperthyroidism is adjuvant therapy. And these can be beta blockers that are typically given for symptomatic relief and can be used as adjuvants with the carbimazole, CPZ, in the first few weeks. And this is typically to make up for, remember, you have to regulate your doses. And then the propanol is a way to ensure that you're not doing any damage in the cardiovascular side of things. So the small doses of a non-selective agent, propanol, 20 to 40 milligrams, 2 to 4 times a day at the beginning. And it's going to help with relief of the palpitations, anxiety, sweating, tremor, all the things related to the cardiovascular side of things. So that's the finishing of the drug treatments. Now let's talk a little bit about what you do for radioactive iodine. So radioiodine is widely used in for the treatment of Graves' hyperthyroidism. It has been the therapy of choice in the United States by roughly 60% of endocrinologists, whereas in Europe, in the UK, there's only 10% of endocrinologists use radiotherapy, in part due to the worry about the side effects of radiation therapy, and in part, obviously, due to costs. How it works is you give the patient a radioactive dose of 600 to 800 million becquerels, and this is administered orally, usually as a capsule or as a solution. And the idea is to achieve erythroid state with the lowest possible risk of hypothyroidism, because obviously you're going to be damaging the tissues by putting in this radioactive compound. Typically, only 1 dose is required to achieve the expected clinical result, and only a few patients need a second or third dose. So by putting in this radioactive compound, the iodine is rapidly incorporated into the thyroid, and the beta emission beta rays are given off because it's radioactive. It's undergoing radioactive decay and radiative decay, and the net effect is the ablation of surrounding tissue. Okay. And this will block then thyroid function over a period of 6 to 18 weeks. And by blocking thyroid function, you then have your TSH levels will try to level out, and hopefully you achieve erythroid steady state. A large proportion of patients become hypothyroid, unfortunately, with radiation therapy and eventually require hormone replacement therapy for life. So this is one of the major complications and side effects of radiation therapy. And in part, it may be one of the reasons why in Europe they want to they limit that approach, because they want to minimize having to treat patients chronically for the rest of their life. So, with that in mind, what are some of the complications related to treating with radioactive 131, high 131? So one of them is you get permanent hypothyroidism. Another is you get transient hypothyroidism. And sorry, my son wants inside at the door. You have transient hypothyroidism. You also get thyroiditis, and quite a number of patients will also get inflammation of the salivary glands, because obviously, and typically this is subdivided temporally into acute, chronic, and recurrent forms. A lot of it just to do with the radiation and the change in the hormones. You also you can get thyrotoxic crisis and nodule formation in kind of short term after treatment, and then this silodentitis that I mentioned to you. And it's mainly just because of the changes in blood flow and the radiation that can occur and damage some of the tissue around that drives the salivary glands. And as I mentioned to you, a large number of patients become hypothyroid afterwards and need radiation therapy. Okay. Now you don't give, and this is example of a patient who developed nodules after treatment. Now you don't give radiation therapy to children for obvious reasons, or to pregnant women, or to lactating women. You don't give it to patients with urinary incontinence, and obviously patients who won't be able to handle radiation therapy, for example, very older, much elderly people. It's particularly good to avoid in smokers, and it may worsen patients with eye conditions. Okay. And typically, in some cases, you will treat patients that have kind of eye conditions. If you have to treat them with radioiodine, you're going to first prepare them by treating them with a steroid, and then later reduce that after 6 weeks. So if drug treatment is not an option or doesn't work, and if you cannot do radiotherapy, the final option available is called thyroidectomy, and this is obviously surgery where you're going to try and remove part of the tissue. Okay, so this is only done in situations where the patient fails to respond to any medical treatment, or they're intolerant to CBZ or PTU, and perhaps at a young enough age that they're going to survive and be able to benefit. What are some of the complications for surgery? You can get nerve damage of the throat. You can get hemorrhage. Obviously, the nerve damage coming from just the fact that you're taking tissue out of the area. Patient can become hypocalcemic, and then the symptoms of this are tingling and numbness in the fingers, toes, and lips, cramps, tetany, or seizure. Tetany is a condition marked by intermittent muscular spasms caused by malfunctions of the parathyroid glands. And remember, the parathyroids are right next door, and it's part of the calcium homeostasis. You can get a pneumothorax, which is a quite serious lung condition. You can get a thyroid storm in patients who are poorly prepared for the surgery. You can have damage to the thoracic duct, damage to the vessels, again, all because of the ablation. And obviously, because of potential damage to the nerves or to the tissue, you could get hoarse voice problems with you're going to get a keloid scar, and you're going to typically get, in late complications, hypothyroidism. So again, some sort of replacement therapy. Okay, this is a classic keloid scar. So typically when you see this, you know the patient has had some kind of thyroid surgery. So what is this thyroid storm? It's a rare, life-threatening condition. It's rapid thyroid toxicosis with hyperphosphatemia, tachycardia, and extreme restlessness, and eventually delirium, coma, and death. It's caused by infection, stress, and surgery, or radioactive iodine in unprepared patients. And management includes the administration of large doses of carbimazole and propranolol, and iodine to block release of the thyroid hormone from the gland, and dexamethasone or hydrocortisone to inhibit peripheral conversion of T4 to T3. In some cases, saturated solutions of potassium iodide can be an emergency treatment for the thyroid storm, as high amounts of iodide will temporarily suppress secretion of thyroxine from the thyroid gland. The dose typically begins with the loading dose, and then 1 to 1/3 mils from thereafter. So thyroid storm can be quite serious. So what's the best marker for thyroid action? So I just want to talk a little bit about measuring TSH and why we measure TSH. So typically you can see here a log scale of a linear scale on top and a log scale on bottom for what is considered the best biomarker of thyroid status. So the shape of the curve typically should be have a tail from 3 on upwards, all right? That kind of tells you the size of this tail afterwards tells you how if there is a potential for the presence of thyroid autoantibodies. If you see this TSH levels are slow to respond to change after about 6 weeks, it's again a sign of potential issues, and you can assume there's normal pituitary function if you don't see if the slow change, if there is a change, then you can assume there's a normal pituitary function. Depending on the treatment, obviously, if you're treating a patient where they had high TSH and then you see this adjustment, then you expect a change in pituitary. So it's all about understanding where you are, where's the patient, and how does that respond. So what does that look like, for example? On the left, this is an example of primary hypothyroidism. So this is the TRH level, right? You're putting in TRH and you're measuring TSH. You stimulate the patient with TRH, and you would expect to see TSH go up if they're normal and their pituitary is functioning normally, right? If you see a situation like this in this nodular goiter, you don't see much change, or with hyperthyroidism, you'll see basically a flat line, right? Because their thyroid is producing so much T4, it's suppressing the pituitary function. So the TRH is basically doing nothing. In the case of hypothyroidism, right, you will have, when you inject in TRH to the patient, you will already have very elevated TSH levels, and you'll see a slight bump, okay? In the case of hypothalamic hypothyroidism, it'll be more these black curves. And if it's pituitary hypothyroidism, there'll be no response from TRH on TSH production. This is just some pathology of what an inactive thyroid containing colloid looks like. And then remember what this would be one that is hyperactive in the case of the Graves' disease that we showed you earlier. And then this is an irregular gland and cut after. What I want you to appreciate is, you lose that nice butterfly shape and you have massive infiltration on the histology of the patient. You can see that here where you lose your nice circular shapes and you've got massive infiltration of these small inflammatory cells into the tissue. A reminder of what causes multinodular goiter. So in this case, you have a lack of iodine, which leads to an enlarged thyroid gland, termed goiter due to hyperplasia and hypertrophy. The gland enlarges to maximize amount of the iodine absorbed, and the increase in size overcomes the hormone deficiency, and the patients become erythroid. This is one of the examples of why it's very difficult to just look at a patient that has a goiter and make a diagnosis. What about a situation where you have diffuse so this is, Hashimoto's would be kind of one enlargement and inflammation, but if you have diffuse multinodular goiter, which is multiple nodules, the problem with this is and you start to see kind of infiltration at a variety of points. The problem with this is it can start to compress the trachea, and the patient will have restricted breathing. So this is why, in one of the few cases where you'll have to have a look by imaging to see if the patient is going to have trouble after surgery. You can see that in this case, this patient really had goiter all the way around the trachea, and it was difficult for them. You see here, the compression is going to damage their tissue, so they may have trouble after recovery, as their trachea will have been softened up and be a problem. And you can see here in this case, the trachea is deviated, right? Because the tissue's been so pushed and forced to adjust from the pressure of the goiter. And so it's a major problem. So Just a quick comment in terms of iodine and thyroid function. So iodine has several effects on thyroid function. In hypothyroid patients, iodine acutely inhibits hormonal secretion within a few hours. The mechanisms are a bit unclear. It's unclear if it's related to the channel or the trafficking. Iodide solutions typically historically were used and it was designed as a replacement for previously using burnt sponge extract that was used before, because obviously sponges came from the ocean. Once a little more was understood about hypothyroidism, then the iodine started to be used in terms and to replace these sponges. And in the 1920s and 1930s, it was thought to be the sole therapy for mild hypothyroidism. So it was recommended for patients to take iodine for many years. Today, iodine continues to have a minor role in the treatment of hypothyroidism, as obviously we appreciate that the complexities of the endocrine system are a little more complex beyond just iodine trapping and the function of the thyroid. A second effect in general of iodine involves inhibition of the thyroid hormone synthesis, as the administration of pharmacological amounts of iodine will, as I mentioned to you, inhibit iodine organification in the thyroid gland, which is going to impact hormone biosynthesis and impact the channel and the enzymes involved for iodine trapping, so TPO, for example. This phenomenon was recognized by a gentleman named Wolff-Chaikoff, and it's kind of called the escape from the Wolff-Chaikoff effect, which is to make sure you don't alter the biochemical pathway of iodine trapping. In patients with an autoimmune thyroid disease like Hashimoto's or the TPRP, the TSH receptor, for example, antibodies, there's abnormal autoregulation of the iodine. Remember, there's that iodine economy, the trapping and recycling of iodine. So in this case, iodine-induced blockade of iodine organification can persist and result in exacerbating the hypothyroidism. So patients with Graves' hyperthyroidism are more sensitive to the inhibitory effect of pharmacological doses of iodine than normal subjects. In these patients, iodine treatment can be slightly more effective, but typically it's not. It's temporary. This is just an example of thyroid nodules by imaging. And in some cases, as I mentioned to you, in less than 1% of patients, you do have thyroid cancers. This is relatively uncommon, and it is quite nasty disease. The main symptoms are a lump or swelling in the neck, but fewer than 10% of the patients have a nodule that can be cancerous. Sorry, let me plug my computer in before it dies. And typically for the treatment of thyroid cancer, you want surgery is followed by radioactive iodine therapy to really make sure that all the tissue and the cancerous tissue is ablated. Follicular adenomas are benign tumors of the thyroid in the follicular cells themselves. Those are one type of thyroid tumor, and then the carcinoma are basically make up four other main types, which can be papillary, follicular, medullary, and anaplastic. Just to show you a benign adenoma versus a tumorous cancer one in terms of pathology. Problems associated with drug treatment. A lot of times it has to do with patient compliance in terms of patient preference, if they want to undergo and have a lifetime replacement therapy or not, or if they want a scar, for example. And if it's patients over 40 years old, again, you have to consider the side effects and what their condition is. And then obviously the chance of recurrence after, say, a thyroidectomy. Cardiac disease is a major one for the cardiovascular side effects. And then remember, we talked a lot about potential for for infection. So you need to understand what's the lymphocyte situation of the patients and to be able to recognize granulocytis quite quickly by doing pathologies of your patients, to be able to recognize whether or not this patient is at risk or if they're producing autoantibodies. So how do we perform a thyroid function test which for monitoring hypothyroidism? In hypothyroidism, a typical thyroid function test results during successful treatment would be measuring TSH levels. Okay, so you want raised TSH and relatively low T3, T4. So this should be treatment. This should aim to reduce that TSH to the lower end of normal. Just as a reminder, what thyroid function levels look like in terms of how we define it. Again, I just want you to be aware of these. You don't have to know these for the exam. I will give you these values and tell you if they're considered, or tell you what the normal values are and let you interpret whether or not something's elevated and what's it mean, okay? I would expect you, though, to understand the treatment flow charts that I've given you in the lecture, so you understand. Okay, here's the flow chart for looking at a patient. Check the TSH, check the free T4, and then how do you respond? How do you interpret if one's primary or secondary? Okay, this is the type of thing I would expect you to know. I wouldn't expect you to memorize the numbers or the values. Importantly, remember that free T4 and TSH are related, right? So you have to understand what's driving the system. You have to remember your negative feedback, okay? So how do you recognize hyperthyroidism versus hypo, and then primary versus secondary? So here, for example, you have relatively low TSH, relatively high T4, and relatively high T3, which would mean you've got hyperthyroidism that's probably driven by the thyroid, and it's some sort of autonomous function of the thyroid where it's not responding anymore, and something like that could point towards TSH receptor autoantibodies, where TSH receptor is being activated in the absence of TSH, right? You're at very low TSH levels here. So this suggests that there's no input from the pituitary, yet the thyroid is still functioning. And remember that high T4 is probably pushing down the TSH, yet there's no drop in T4 levels. Just a short word about the parathyroid glands. Parathyroid glands are relatively small size, of about the size of a grain of rice, so really small compared to the thyroid. You have four of them. Two are superior and two are inferior. They're very difficult to locate, and when doing a thyroidectomy, the surgeon has to be extremely careful to try and not remove the parathyroids. because if you remove the parathyroids, blood calcium levels will fall, muscles, including respiratory and laryngeal, go into tectonic contraction, and often the patient will die. So just to remind you, the chief cells of the parathyroid glands are producing parathyroid hormone, PTH. It's an effective hormone receptor. So it binds to the PTH receptor, and it's a receptor that binds to a 34 amino acid hormone. It acts to increase ionic calcium concentrations in the blood. Calcitonin then becomes produced by the C cells, remember, in the C gland, in the thyroid gland, which then acts to decrease those calcium concentrations. So PTH hormone from the parathyroid essentially acts to increase the calcium concentration in the blood via this parathyroid hormone receptor. The parathyroid hormone receptor is located in bone and kidney, whereas the parathyroid, and that's the parathyroid receptor 1, and parathyroid receptor 2 is located predominantly in the central nervous system, pancreas, testes, and placenta. In terms of half-life, PTH parathyroid hormone half-life is approximately 4 minutes, so it's cleared extremely quickly. And that's why the delicate balance between parathyroid hormone and calcitonin. So just a quick summary of a lot of the things that we've talked about today, or over the series of these lectures, for thyroid. In terms of the molecular side of things, as a reminder, what's the process? You've got TSH coming in from the pituitary, stimulates the thyroid. This leads to trapping of iodine at the basement cell membrane, movement of activation of sodium iodine symporter, and movement of iodide across. Iodide is converted to iodine by TPO. Then you get synthesis of polypeptide chains onto thyroglobulin, onto these tyrosyl groups. You get transport of newly formed thyroglobulin to the cell surface in small apical vesicles. Iodination of thyroglobulin of MIT and DIT to form T4 and T3. Retrieval of thyroglobulin by micropinocytosis, or endocytosis, you can say, leads to these colloid droplets. Fusion of lysosomes with these colloid droplets and proteolysis of the thyroglobulin drives actual release of T4 and T3. Then these will diffuse into the bloodstream, and that's and then obviously feedback to the pituitary and go on and activate thyroid hormone receptors throughout the body. And then you've got recycling of MIT and DIT back and to obtain the iodide again for another round. So in general, things I want you to focus on, well, this is the things that we've covered, and then things that I want you to focus on here in blue. I want you to understand the gross anatomy of the thyroid gland. I want you to be able to reproduce that last slide about how thyroid hormone synthesis occurred, and then understand generally the regulation between the hypothalamus and the pituitary, because that is essential for understanding when I give you a clinical situation of a patient. How do you tell if a patient's hypo or hyper? I want you to understand the properties and functions of thyroid hormones. So remember all those physiological effects that we talked about, basal metabolic rate, bone, these kinds of things. And then I want you to be able to diagnose some of the simple things that we talked about. So if I give you a patient with Graves', you'd be able to identify it. If I give you a patient with Hashimoto's, you'd be able to identify it, and then tell me how you're going to treat that person, how did you diagnose them, and some of the mechanisms therein, okay? And then specifically, I want you to be able to give me examples of how you do drug therapy, what happens if you need to do surgery, and replacement therapy, and obviously the pros and cons of radiotherapy if we need it. Okay? And I've put a couple readings on QM Plus, and I'll try to put one more, and then I will finish uploading the recordings. And thank you very much. And you'll have a break. I think Carlos is going to dial in 30 minutes. Okay?